In this video, we'll learn about coarctation of aorta. Coarctation of aorta, it's a congenital condition where there is a narrowing of the aorta. And we all know aorta is a major artery that supplies the blood to the whole body. We all know the arch of aorta has three main direct branches. This is the brachiocephalic trunk, the second would be left common carotid artery, third is subclavian artery. So this is the third artery which usually supplies the subclavian artery supplies your left arm. So this usually the most common site of coarctation of aorta is after the origin of the subclavian artery. So sometimes they tell like this is where the ductus arteriosus comes and attaches. Okay, so the coarctation of aorta can be post-ductal, meaning after the ductus arteriosus or before the ductus arteriosus. So the types of coarctation can either be a pre-ductal coarctation or post-ductal coarctation, but post-ductal coarctation is more common when compared to pre-ductal. So this is what I have drawn. So imagine this is a ductus arteriosus. Post-ductal origin of coarctation of aorta is the most common type of coarctation. Coming on to the causes, the exact cause of coarctation is not known because it's a congenital defect. Some anomaly might be there during the fetal development. And also remember, coarctation of aorta is commonly associated with this Turner's syndrome. So now what are the signs and symptoms in case of patients of coarctation of aorta? Here now just imagine this is the narrowing of a blood vessel which is called coarctation of aorta. So what happens is the blood which is coming from the heart via the aorta is not able to pass through the thoracic or abdominal aorta. So what happens is more blood flow via these branches to head and neck area, right? Head, neck and upper limbs. So the blood flow to the upper limb is more, so blood pressure is very high in the upper extremity. So relatively the growth of these organs also would be higher, and the blood pressure is higher in the upper limb and head and all. So the patient will present with epistaxis, meaning the nasal bleed. Patient also complains of headache, and these are mainly because of hypertension. Now the blood flow to the lower limb is reduced, right? So because of reduced blood flow, the blood pressure is less in the lower limb. So there is a discrepancy in the blood pressure between the upper limb and the lower limb, and there will be the growth of the lower limb is also reduced. Okay, maybe the patient sometimes present with narrow hip and very short legs when compared to upper limbs. So, and when the patient walks for a certain distance, he has a severe pain in the calf, which we call it as claudication, and there is also cold legs when compared to upper limb. That indicates that there is reduced blood flow to lower limb. Now, when you examine the pulse, so when you check for the carotid pulse, it will be a high volume pulse. As I told, there's a more blood flow to the head and neck area. And the pulsatile arteries are found around the scapula. That is because, see now, the blood is not able to go from the arch of aorta to the lower extremities. So what happens is now, there will be so many collaterals which will open, okay, meaning some blood vessels will for example, if I want to name few, there will be like this internal mammary arteries, scapular arteries, superficial intercostal arteries. All these arteries which are present in between the ribs, they start opening up, and they will divert the blood from the arch of aorta to the lower extremity here. It will finally drains into the descending thoracic aorta. These blood vessels and all these collaterals will open up. So that means there will be pulsations in and around the scapula. Normally we don't find these arteries, but if you find all these pulsations around the scapula, just suspect coarctation of aorta. And also if you see the pulse, when you check in the upper extremity and lower extremity, you can see the radiofemoral delay. Right. Now, when these are the findings on examination, okay, meaning just remember, just to summarize, there will be a prominent pulsation in the neck area, and all these pulsatile arteries around the scapula or intercostal spaces in the back, we call it as Sussman's sign. And JVP is not raised because we know the problem is in the, if the problem is in the arch of the aorta, it means it is because of the back pressure, it is a left ventricular ventricle is the one which suffers. Okay, so there will be you can expect left ventricular hypertrophy, but right ventricle and right atrium, right heart is normal, so JVP and all will not be elevated in these patients. So, and there will be a major difference between the blood pressure in upper limb and lower limb. Remember, blood flow is more to the upper limb and head and neck area. So BP is high in the upper limb but low in the lower limb. Now moving on to investigations, you can do a chest X-ray. The prominent finding in chest X-ray is what you see is sometimes this erosion of the under surface of the ribs, you can see, especially from third, fourth and ribs downwards, after third rib onwards, okay, because first and second ribs, no, they get the blood supply from the subclavian artery. They are not branches from the aorta. So what happens is all these intercostal vessels are the collaterals are opened up, right? They actually run along the undersurface, all these intercostal arteries. Because of increased blood flow via these intercostal arteries, there will be erosion on the undersurface of the ribs, which is called as rib notching, otherwise called as dock sign. It is called dock sign. You can also do echo, where you can find the pressure gradient in the descending aorta or the left ventricular hyper, and also you can see left ventricular hypertrophy also can be noted. In ECG, if you do, you can find the features of left ventricular hypertrophy. So just to summarize the investigations, chest X-ray shows your erosion on the undersurface of the ribs, and also sometimes the dilated heart also can be noted. You can do ECG and echo. So now how you want to treat these patients, okay? Usually intervention is needed if the pressure gradient across the coarctation is more than 30 mmHg. If the pressure gradient is pressure difference is too high, it means too much less flow in this segment, okay? In the lower segment, we need some intervention. And as you know, medically you can just give medications to reduce the blood pressure. So you can prescribe antihypertensives, but surgical treatment is what is needed, where if it's a very small constriction, what you can do is just cut that segment. End to end anastomosis can be done. But if the segment is very long, if the narrowing is too long, what you can do, if it's an extensive narrowing, what you can do is you can keep a prosthetic connection connecting the pre-coarctation segment to the post-coarctation segment. So you can place a vascular graft, which will the main idea here is to increase the blood flow to the lower limb.